Uh, Good afternoon, everyone. So today it will be my first lecture in regular batch, and today onward we will be discussing the major part of medicine. So before discussing and before starting the lecture, so let's see how to study medicine, because medicine is a very lengthy subject. Some says it is more of a general knowledge like subject. Like if you prepare, you might not get questions which you can solve, or if you don't prepare but you can get medicine MCQ which you can easily solve. So more or less a GK type. And if you study medicine thoroughly, you will not get time to study other subjects, and if you do MCQs, there is no guarantee that these MCQ will be repeated again. So how to study this subject, a tricky subject, medicine? So there are some ways which is based on the recent pattern of exams and the feedback of the students ki how to study medicine. All right. So Agra. Hmm. Okay, so the strategy to read medicine is number one, read your notes, class notes within 24 to 48 hours. Okay, so let me first introduce myself. I am Dr. Arvind, and I will be taking your remaining medicine topics. So class notes within 24 to 48 hours is must, and this holds true for other subjects also, like surgery or ops gynae, PSM. Along with that, you can read double A, that is Amit Ashish, you can read, and that is slightly better than Mudit Khanna. But if you have already purchased Mudit Khanna and have done a single reading, then do not switch over to Amit Ashish. Continue with the Mudit Khanna. And plus some selected topics from Harrison. So what will be these topics? We will discuss after the completion of each system. Like if we'll do GIT, then I'll tell you what are the important topics that you should read from Harrison. So class notes, double A, and selected topics from Harrison. This will be your strategy to read medicine. And if you have some time left, then you can add maybe 2 years of NEET oblique all India questions, and this you can get. You can ask your bookshops, they will have this question bank of last 2 years. Remember, the question will not be repeated, but they will give you idea that what are the important topics that are asked in the questions. So most important things from now onward is the topics. You'll get questions from topics, though you may not get repeated questions. So based on this strategy to study medicine, let's start with today's topic. And today's topic will be acid base and the GIT. So first we'll start with the very basic, that is acid base disorders. So these acid base disorder will be not purely medicine. It will include your biochemistry, it will include your physiology, some bit of pharma, and some clinical aspects from medicine also. So let's understand first the basic physiology of these acid base imbalance. Normal arterial pH, it will say there is a range of normal arterial pH. It is 7.34 to 7.44. 7.44. So to maintain body pH within this range, if there is some disturbance, we have compensatory mechanisms. To control the pH within this range. So number one compensatory mechanism which act immediately acting is the chemical buffers. In the body, chemical buffers in the body, and the examples of important chemical buffers is the bicarbonate, carbonic acid system. So how does it work? Like suppose if in the body there is say addition of H ions. So the H ion is a acid, a strong acid. So this will be converted into bicarbonic acid, which is a weak acid. So a strong acid is added, it will convert into a weak acid, and body will try to maintain the pH. Similarly, this can shift towards the other side also, like if there is alkalosis, so the weak acid, in cases of alkalosis, weak acid will dissociate into H plus and bicarbonate. So alkalosis, it is providing a stronger acid, it is providing a stronger acid to the body, and that will help in controlling the pH, So this is the, we can say, a very important immediately acting buffer system of the body, bicarbonate carbonic acid system. Then second is the proteins in the body. So protein contains two important groups. One is the amine group, which is a base, and second is the carboxyl group, which is a acid, So it has got a excellent buffering capacity. Suppose if there is addition of acid in the body, like H plus, so it will bind preferably with the base, that is the amine group, and its concentration will decrease in the body. While if there is a bicarbonate, that means alkalosis is there, it will preferentially bind to the acidic group. So alkalosis binding with carboxyl, acidosis binding with amine group. So help in neutralizing these excess of H ion and bicarbonate in the body. Now third important is the hemoglobin. Chemical buffer is hemoglobin. So how does hemoglobin help? We'll understand with the basic diagram. This is blood, and this is arterial side, this is the venous side. So in the arterial blood, hemoglobin is binding with oxygen. Are these immediate acting? Yes, these are immediate acting. They work within minutes to hours to balance the pH. And remember one more important thing that if these chemical buffers are working, patient might not get clinical manifestations of that acid base disorder, because pH is neutralized. As soon as there is some source of disturbance, chemical buffers are working, they will make the pH within the range, and patient might not get any symptoms or signs of acid or base disturbance. So hemoglobin is in the arterial side is binding with oxygen, and when it is going to the venous side, it will release its oxygen, and when it releases its oxygen, it becomes negatively charged. So we can say the deoxygenated hemoglobin after losing oxygen is negatively charged. So what will happen if it is negatively charged? H ions will bind with hemoglobin, So it is a compensatory phenomena that whenever there is acidosis, oxygen dissociation from hemoglobin increases whenever there is acidosis, so that Hb become more negatively charged and it is able to bind with the H ions. It is able to bind with the H ions and neutralize the pH. And this effect we have seen in the physiology, like there is increased oxygen dissociation from hemoglobin in acidosis. This is known as Bohr's effect. Similarly, when there is a alkalosis, there will be oxygen dissociation will become less. So there will be more availability of H ion in the blood that will neutralize the pH. So with alkalosis, oxygen dissociation decrease, so that hemoglobin remains binded with oxygen, and there will be more availability of H plus in the blood. Now, the fourth important chemical buffers, they are phosphate and sulfate. Again the mechanism will be the same, like phosphate binds with 2H plus, leading to H2PO4. Phosphatidic acid, and sulfate, it binds with 2 molecules of H ion and form sulfuric acid. So there is an addition of H ions, they bind with the phosphate and sulfate to form a slightly weaker acid than the H plus. So these are the important immediately acting compensatory response to the body. Now the second compensatory response is through respiratory system. So it works within hours whenever there is any acid base disturbance. HbO2 dissociation curve, it dissociate to the, we have just discussed that whenever there is acidosis, more dissociation, alkalosis, less dissociation. Then what is the most important chemical buffer? Out of these is the bicarbonate, carbonic acid system. So respiratory system, it works within hours. And how does it work? Whenever there is a low pH, that is if there is some acidosis, it stimulate respiratory center, low pH. So when respiratory centers are stimulated, it will produce hyperventilation. So this hyperventilation leads to CO2 washout. As a result, PaCO2 will decrease. Remember, CO2 is acidic. So whenever there is acidosis in the blood, a second form of acid is being excreted out of the body through lungs. So it is able to maintain the pH. It is able to maintain the pH. And similarly, when there is an increase in pH, it will inhibit respiratory centers, and that will cause hypoventilation. As a result, when there is a alkalosis, acid will retain in the form of carbon dioxide. So carbon dioxide PaCO2 will increase. PaCO2 will increase, so that will able to neutralize the alkaline pH. Then third buffer is kidneys. And remember, the peak onset or the effect start coming after 48 hours. So we can say kidneys are slow acting chemical buffers. So let's see what is the important mechanism in kidneys by which it is able to compensate for the acid or base in the body. So let's make a diagram of kidney tubules. So upper one we make the proximal tubule, and downward we have the distal tubule of alpha intercalated cell. Distal tubule, alpha intercalated cell, and this is the proximal tubule. So the mechanism by which kidneys balances the pH, the most important is through proximal tubule. So here there is reabsorption of bicarbonate. Remember, most of the bicarbonate, 90% of the bicarbonate will be reabsorbed through proximal tubules. So this is the luminal side, and this is the blood side. So whenever there is a disturbance of pH in the blood, suppose pH is decreasing, there is acidosis in the blood, bicarbonate absorption increases. So similarly, if pH is high, bicarbonate absorption decreases. So the first and the most important kidney mechanism is the reabsorption of bicarb from proximal tubule. Then secondly, distal tubule also help in the acid base balance. There is a channel here in the alpha intercalated cell, and this channel is hydrogen ATPase. In the distal tubule of alpha intercalated cell. So what does this do? It brings the blood H ion. So blood H ion, it is causing it to be excreted in the urine. If there is a low pH. If there is a high pH, this H ion excretion decreases. So second is H ion excretion from distal tubules. But what happens? Suppose it is a case of acidosis. H ion is excreted into the lumen. There is a property of this H ion that even if it is excreted in the lumen, it can be reabsorbed back reabsorbed back into the blood through back diffusion, and it will we can say if HIN is excreted, it can diffuse back into the blood, diffuse back into the blood. So what proximal tubule do in order to make this HIN to be excreted in the urine? The main effect of this channel will come when it is excreting HIN, and HIN is excreted into the urine, then it will be effective. If it is secreting and it is going back into the blood, it is not effective. So proximal tubule, what it do, it releases, synthesize more of NH3. So ammonia is made, synthesized from the proximal tubule and is excreted into the urine, excreted into the urine. So what does that ammonia do? It will bind with H plus into the lumen, and it will form NH4 plus, NH4 plus. So this NH4 plus is not reabsorbable, it is excreted in the urine, it is excreted into the urine. So whatever the hard work of this H plus ATPase, the hard work is it is excreting H plus, so ammonia will come and bind with this H plus forming NH4, and this will be excreted into the urine because it is not absorbable. So third mechanism is ammonia production by proximal tubule, and in the lumen what it is doing, in the lumen this ammonia is binding with H plus, it is sort of trapping H plus so that it is not being able to absorb, so it is trapping the H plus, so leading to proton trapping. So this is the phenomena of proton trapping, that ammonia remain binded with the H plus and form the non-absorbable NH4 plus, NH4 plus. So these are the three important mechanisms by which kidneys work in order to balance the pH, in order to balance the pH. So there is a very basic question which comes in the exam is, suppose in a case of in acidosis, this acidosis is systemic acidosis, what will happen to urinary bicarb? They will ask you whether they will increase or decrease. So if there is a systemic acidosis, bicarb absorption increases, so in the urine it decreases. Very good. And what will happen to urine NH4 plus in systemic acidosis? In systemic acidosis, it will, very good, it will increase, it will increase. So remember this very basics, very basics. In acidosis urine bicarb decrease and urine ammonia will increase. Other way around, if there is a alkalosis, the manifestations will change in the urine. In alkalosis, systemic alkalosis, urine bicarb will increase while NH4 will decrease, it will decrease. So now moving on to what are the disorders of acid base balance. On the basis of this very basic physiology, very basic physiology. So let's come to the primary, we will make a table, primary disorder, what is the primary mechanism, or we can say the main mechanism of that disorder, of that disorder. Then what is the compensatory mechanism and what is the compensatory response. And remember, this table will be very important for further analysis for solving MCQ, for solving the problems of acid base disturbance. So first primary disorder is metabolic acidosis. Primary disorder is metabolic acidosis. So let's see what will be the main mechanism or a primary mechanism which is causing clinical metabolic acidosis. So logic says it should be increase in H plus. Yes, that is true, that the starting mechanism can be increase in H plus. But remember, whenever there is a increase in H plus, the most important chemical buffer was bicarbonate. So bicarbonate will bind with H plus, forming a weak acid, bicarbonic acid. So ultimately, what is becoming deficient in the body? Bicarb is becoming deficient in the body. So there is a decrease in bicarbonate. Remember this point. Clinical disease will come when chemical buffers become saturated and there is no we can say a potential store of bicarbonate, so they get depleted. Before depletion, they will able to compensate for high H plus. So it is the decrease in the bicarbonate which causes a clinical metabolic acidosis. There can be some other exceptions also that we will study, ki what could be the other mechanisms for metabolic acidosis. Now, the compensatory mechanism will be hyperventilation. Remember, metabolic things are usually acute, so they will be compensated. They will try to get compensated by the respiratory system. Also, kidneys will also start working, but they work best after 48 hours. So before 48 hours, it is the lungs which are the main compensatory mechanisms. So the compensatory response will be a decrease in PaCO2. PaCO2 become less. Now, second is metabolic respiratory alkalosis. This we can say as a compensatory respiratory alkalosis. Compensatory. It is not the primary disease. It was in response to metabolic acidosis. Now, metabolic alkalosis. Primary mechanism is a increase or gain of bicarbonate. Remember, there could be other reasons for metabolic alkalosis besides increase in bicarbonate, but we are doing the main important primary mechanism. So compensatory mechanism will be hypoventilation. So if you lost connection, what you can do at the end of the class, you can see initial half an hour of the lecture that will not interfere with understanding of the disorders which we'll discuss from now onwards. So hypoventilation will be a compensatory mechanism, and compensatory response will be increase in PaCO2. Third is respiratory acidosis. So it is starting from the lungs. So the primary mechanism is increase in PaCO2. This is the primary mechanism. That CO2 is increasing. This leads to, because the pathology is originating from lungs itself, so it will not be able to compensate for that acidosis. So now the main load will be on the kidneys. So there will be increased bicarb reabsorption from kidneys. This will be the main compensatory mechanism, though we have seen that it could be H ion excretion, ammonia also, but remember, increased bicarb reabsorption from the kidneys. As a result, serum bicarb will increase. Compensatory response. Then fourth, respiratory alkalosis. Respiratory alkalosis, there is a primary decrease in PaCO2 and that will cause a decreased bicarb reabsorption from kidneys. As a result, serum bicarb will reduce. So let's see this table as a whole and we will make two conclusions from this table, and these are very important conclusions and this will be a caution to you also. First thing, in this table, first conclusion is the direction of bicarb and PaCO2. So just look at the direction of bicarb and PaCO2. If it is decreasing, CO2 is decreasing. Bicarb increasing, CO2 increasing. Similarly, PaCO2 increasing, bicarb will increase, CO2 decrease, bicarb will decrease. So, first conclusion, bicarb, CO2 change in same direction. Number one. Second, never ever make a diagnosis on the basis of isolated value of bicarb or PaCO2. This is a very common mistake that we do. We just look at the isolated value and say that it is acidosis or alkalosis as a primary condition. For example, if you look at the respiratory alkalosis, you see that bicarb is decreasing. And our conclusion will be, whenever we see low bicarb, it is metabolic acidosis. No. If it is a compensatory response, it is respiratory alkalosis. Similarly, whenever we say PaCO2 is increasing, our first conclusion is that the primary disorder is respiratory acidosis. No. If it is a compensatory response, then the primary condition will be metabolic alkalosis. So, second conclusion is never ever make a diagnosis with isolated value of bicarb or CO2, no meaning. Isolated values, no meaning. So how to say that it is a compensatory response or a primary response? That we will do in the analysis part. So remember this table, it will be very useful later on also. Now starting with individual disorders, so let's start with metabolic acidosis. And what are the causes of metabolic acidosis? So conventionally, metabolic acidosis is divided into two groups. One is high anion gap metabolic acidosis. High anion gap. Remember this anion gap means it is a serum anion gap. And second is non-anion gap metabolic acidosis. Non-anion gap. So let's understand this anion gap. And remember, in acid-base disturbances, we will come across 3 or 4 gaps. So gaps are very important. So first let's do what is this anion gap. Read it as serum anion gap if nothing is mentioned, and on the basis of that we will categorize metabolic acidosis into different groups, high anion gap and non anion gap. So let's understand the literal meaning of anion gap. Anion gap is equal to the difference between unmeasured anions minus unmeasured cations. This is the literal meaning of anion gap. So let's understand what is this meaning of unmeasured. Unmeasured means ion which is very low in blood physiologically. So a very simple meaning of unmeasured, that a ion which is present in a very low quantity in blood physiologically. It is so low that we'll say it is unmeasured. It is unmeasured. While measured means opposite, ion which is present in a good quantity in the blood physiologically. So how to calculate this unmeasured anion minus unmeasured cations, which is a anion gap? So we have studied in physiology that total anions in the body are equal to total cations. This is true that all the negative charges will be equal to all the positive charge. If this does not happen, what will occur? The body will become charged. So body is electroneutral. So we divide total anions into two groups. One is measured anions plus unmeasured anions. So total we have split: measured, which is present in a very good quantity; unmeasured, very minute quantity. Total cations we again split into measured cations plus unmeasured cations. So we have split. Now coming to what are the examples of measured anions in the body. Measured anions in the body are bicarbonate plus chloride. They are present in we can say a good quantity in the blood, plus unmeasured anions equal to measured cation in the body. Main is sodium plus unmeasured cation. So our equation is expanded in this form. Now what is the original definition of anion gap? Anion gap was unmeasured anions minus unmeasured cations. So what we will do? We will shift this unmeasured cation on the left side and these bicarb and chloride on the right side. So we have studied in class 5th mathematics that if a value is going to the other side, its sign will change. So what will happen? Unmeasured anion minus unmeasured cations equal to sodium, that will remain here. Bicarb chloride are coming to the right hand side, minus bicarb plus chloride, bicarb plus chloride, and this become the formula of anion gap, because unmeasured anions minus unmeasured cations is sodium minus chloride plus bicarbonate. The normal value of anion gap is, remember, plus 12 millimoles per liter, is 12 millimoles per liter. That means in the body unmeasured anions are slightly more than unmeasured cation, therefore this value is plus, this value is plus 12 millimoles per liter. And remember one more important thing, that your guidebooks take potassium as measured cation. No, potassium is unmeasured cation. Standard textbook does not take potassium in the calculation, potassium in the calculation. So let's see what are the examples of unmeasured cations in the body and unmeasured cations in the body. So what is the range of anion gap? Normal. So what you can do? Plus minus 2. That means 10 to 14 is the normal range of anion gap, normal range of anion gap. So plus minus 2. Now unmeasured cations are more in body? No, unmeasured cations are less as compared with unmeasured anions, therefore this is plus, this is plus. Unmeasured are slightly more than the unmeasured cations, so when you minus it is positive, it means unmeasured anions are more than unmeasured cations, unmeasured cations. So let's do some examples of unmeasured anion in the body. That means they will increase whenever there is some pathological condition, or they will be very less physiologically, they will be less physiologically. So example is acetate, negatively charged, aceto, acetate, beta hydroxy butyrate. So negative, 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 they are anions, negatively charged, and they are unmeasured because physiologically they are very less in the body, they are very less in the body. Then lactate, then salicylate, oxalate, formate, then sulfate, phosphate, and of course albumin. Albumin is negatively charged. This is considered as unmeasured anion, unmeasured anion. Then examples of unmeasured cations, they are magnesium, calcium, potassium, lithium, and positively charged immunoglobulins, positively charged immunoglobulins. So let's understand why calcium is unmeasured. The normal value of calcium, we all know that normal calcium ranges from, and remember here is also a very important point to note, is it is 8.5 to say 10.5 milligram per deciliter. Remember, but anion gap is taken in which units? Millimoles per liter. So if we convert calcium, this is total calcium, we are taking example, total calcium 8.5 to 10.5, and 50% of it is bound and 50% is unbound. So let's say the total calcium 8.5 to 10.5. So if we convert this into millimoles per liter, it comes out to be 2 to 2.5 millimoles per liter, and out of which the free calcium, which we call as ionic calcium, will be 1 to say 1.20 millimoles per liter, or a free calcium, So as compared with the normal sodium value 135 to 145 millimoles per liter. So comparing this value, which is in hundreds, and the value which is only 1, so we will consider this as a unmeasured in contrast to a measured one. Therefore calcium, magnesium, potassium, they are all unmeasured cations. So let's understand, when will anion gap increases? It will increase either unmeasured anions, they increase, or unmeasured cations, they decrease. So high anion gap is seen when there is increased in unmeasured anions or a decrease of unmeasured cations. This will be the conditions of high anion gap state. We are not talking about for acidosis, these are high anion gap states. Maybe acidic, maybe without acidosis. So let's see, high unmeasured anions, what will be the conditions where they are increased? So these will be acetate, acetoacetate, beta hydroxybutyrate. So they increase in the body, that will lead to high unmeasured anions. Then lactate increases, that will be a case of high anion gap state, because there is increased in unmeasured anions. Similarly, decrease in unmeasured cations like calcium, magnesium, if they are low, anion gap will increase. Immunoglobulins, they decrease, anion gap will increase. So these will be the high anion gap states. But what we are more interested, in high anion gap acidosis. It means it will be those conditions in which either there is increased in unmeasured anions along with acid in the body, or decrease unmeasured cation with acid in the body. So out of this, the disorder which causes acidosis as well as high anion gap are increased in unmeasured anions. Let's see. Unmeasured anions, we have done the example like acetate, acetoacetate, beta hydroxybutyrate. So when will these anions increase in the body? They will increase when there is increase of acetic acid. If it is increased in the body, what it is bringing? This is bringing the acid with it, then acetic acid, they are bringing acid in the body. Beta hydroxy butyric acid, it is bringing acid in the body. So to understand it, for example, we'll take acetic acid, basic. So if acetic acid is coming in the body, and we all know, yes, you are right, these are ketone bodies, so ketoacidosis, any ketoacidosis will bring these acids in the body. But body has compensatory mechanisms. So what will happen? That this acetic acid will lose H ion, and this H ion will be neutralized by bicarbonate. So body will try to compensate for this acid. Bicarbonate will bind with the acid, and what will be formed? It is acetate. It will be acetate. So acetic acid comes in the body, and bicarbonate will bind with the acid component, which is the H plus component, and what is left behind? Acetate. What is left behind? Acetate. So acetate concentration increases. This is responsible for unmeasured anion. So it will increase. Plus in body, what is become deficient? Bicarbonate is being consumed because it is binding with the acid component. So bicarbonate deficiency. So this is causing acidosis. So in order to have high anion gap acidosis, two things should be fulfilled. One is high anion gap, and second is acidosis. So high anion gap is provided by example acetate, which is a negatively charged, and acidosis is provided by deficiency of bicarb in the body, which is causing acidosis. Similarly, if lactic acid is produced in the body more, what it will do? It is acid. It will try to bind with the bicarbonate. So bicarb will bind with the acidic component. It will be lactate, which is formed along with bicarb deficiency. So there is a increased supply of lactate in the body, which is unmeasured anion, and body is becoming simultaneously deficient in bicarbonate. So there is acidosis. So let's make a list of the disorder which produces unmeasured acids, unmeasured anions along with the deficiency of bicarb. So first group was high anion gap acidosis. So first group was ketone bodies. Example was acetate, acetoacetate, and beta hydroxybutyrate. So we will call it as ketoacidosis. In that list, second cause was lactate production was more, lactic acidosis. Third, sulfate and phosphate, salicylate, oxalate, formate. Actually, these are the product of salicylic acid. They are the product of methanol, that is toxins. So third group we'll call it as a drug overdose or toxins. And fourth, the increased level of sulfate and phosphate. Remember, the main cause of high sulfate, high phosphate is decreased excretion, and they are excreted by the kidneys. So if there is a renal failure, so these are only 4 causes of high anion gap acidosis. Ketoacidosis, lactic acidosis, drug or toxin induced, and renal failure. There is no fifth category. So whatever will be the cause outside these reasons or etiologies, that will be non-anion gap acidosis. So coming one by one, first is ketoacidosis. What are the causes? So let's see. Ketoacidosis is of 3 types. So first is based on the history. Diagnosis is very simple. If history is given as so history is given as a patient is a case of type 1 diabetes with non-compliance of insulin. So patient is not taking insulin for a couple of days. Now landed up into acidosis. Most likely diagnosis will be diabetic ketoacidosis. So this will be the history which will be given. Now, if history is prolonged fasting, so patient is not eating for many days. So what will happen, that because of gluconeogenesis, there is a mobilization of fatty acids, and these fatty acids will make glucose, but at the expense of ketone bodies. So this will be the pathogenesis of second ketoacidosis, prolonged fasting, that will stimulate gluconeogenesis and fatty acid will be mobilized, lipolysis, so glucose will be made along with ketone bodies, and this diagnosis is known as starvation ketoacidosis. Third is history of alcohol binge. That patient has consumed a good amount of alcohol and this alcohol is metabolized to, we all know, it is metabolized to acetaldehyde. So it is aldehydes, and remember, aldehydes are the substrate for the production of salicylic acid. Causes salicylate in the body. We are coming to that. Salicylic acid, that will be under this category, a drug overdose or toxin induced, which is high anion gap acidosis. So acetaldehyde will be a substrate for acetic acid, acetoacetic acid, beta hydroxybutyric acid. So aldehyde will make ketone bodies, due to alcohol binge. So this condition is known as alcoholic ketoacidosis. Alcoholic ketoacidosis. So history will be very important. It can differentiate all three conditions, but sometime what happens, even a patient of type 1 diabetes can develop starvation ketoacidosis. So this is not mandatory and hard and fast rule that type 1 diabetes always present in diabetic ketoacidosis. If there is a prolonged fasting, starvation, patient can have starvation ketoacidosis also. So what is the parameter which distinguish these three? And that is blood sugars. So always look at the blood sugar in the question. Essential criteria for diabetic ketoacidosis is blood sugar should be more than 250. In starvation ketoacidosis, the blood sugar remains normal till very late stages, because gluconeogenesis is able to maintain blood glucose values. While in alcoholic binge, what happens that most of the patients they have a damaged liver. Patient is not taking any food, only taking alcohol. So there will be more chances of, because if patient is not taking anything, gluconeogenesis should occur, but it occur in the liver normally. Main organ is liver, but if liver is damaged, gluconeogenesis will not take place. So it will have usually low blood sugar values, because gluconeogenesis, glycogenolysis, the compensatory mechanisms which take place in the liver will not be so effective, and usually the sugars level are on a lower side. So this is a very important investigation, blood sugar values, on the basis of which we can decide the type of ketoacidosis. Now the one more point is you have to look for to make a diagnosis serum ketones, and the main serum ketone which is present in all the three disorder is beta hydroxybutyrate. It is positive in all three. So that is the main ketone bodies which is produced in all three type of disorders. While just make a basic fundamental clear that urine ketones are not reliable in making a diagnosis of ketoacidosis, whether it is diabetic, starvation or alcoholic. So urine ketones are not reliable. Reason being, what we are measuring in the urine ketones? Urine ketone are measuring acetoacetate. So if this is positive, then ketones will be positive in the urine, and acetoacetate is made from beta hydroxybutyrate. So acetoacetate is measured in the urine dipstick, and it takes a few hours that beta hydroxybutyrate will be converted into acetoacetate. So it takes approximately, we can say, 6 hours that it is converted into acetoacetate. So there can be two situations. First, patient presenting before 6 hours of onset of ketoacidosis, suppose. So before 6 hours of presentation, beta hydroxybutyrate will be there in the blood, but acetoacetate will not be synthesized yet. So it will be negative in urine. Negative in urine because approximately 6 hours takes to make acetoacetate. So before 6 hours, if we do urine ketones, it will be false negative. That means disease is there, but it is showing a negative result. Negative result. Then acetoacetate remain for 12 hours in the blood. Means after its synthesis, it remains in for 12 hours. So if we do urine dipstick within 12 hours of recovery, so what will happen? Beta hydroxybutyrate will not be there in the blood because there is a recovery, but till 12 hours acetoacetate will be present. Acetoacetate will be present in the urine, so it gives a false positive. False positive. Hence, urine ketones are not a reliable method to diagnose any type of ketoacidosis. Any type of ketoacidosis. Now, briefly we'll do the treatment. So we'll do the treatment of each disorder at the same time when we are discussing the etiology and important clinical features. So treatment. First we'll see the treatment of diabetic ketoacidosis, then starvation ketoacidosis and alcoholic ketoacidosis. Remember, the mainstay of treatment for diabetic ketoacidosis, the essential treatment, remember, is IV fluids. This is essential. And which IV fluid we give? We give normal saline. We give normal saline. Do not give ringer lactate. Do not give ringer lactate. Second is insulin. And the preferred method of giving insulin is intravenous. Because subcutaneously or intramuscularly, patient is in dehydration, so there will be a shock, so absorption will be less. Absorption will be less. So IV insulin is given because of the vasoconstriction. So IV insulin given is a regular insulin. Is a regular insulin. So question is why insulin is given IV? Because of vasoconstriction. Subcutaneous absorption will be less. Subcutaneous absorption will be less. Therefore, we have to give it intravenously. Then why not RL? Why not ringer lactate? Okay. So this we'll discuss when we'll finish the treatment of each individual disorder. Third, potassium replacement. Remember, it will be even if potassium is normal. Potassium is normal. How will hypoproteinemia will affect anion gap? Because protein bound ion will be also differ. Yes, that will affect anion gap. So after high anion gap, we'll discuss the causes of low anion gap. And so we'll see how hypoproteinemia will affect the anion gap. So after doing high anion gap conditions, so potassium is replaced even if serum potassium is normal, because what we are giving insulin, and insulin causes a shifting of potassium inside the cells, so body will become hypokalemic. hypokalemic. So potassium replacement even if serum potassium is normal, because insulin cause hypokalemia. And fourth important, this you must have read in questions also, exogenous bicarb. Remember, exogenous bicarb replacement should be avoided. It should be avoided. Reason is, and that reason will explain why we are not giving ringer lactate also. So that reason is sufficient. So why exogenous bicarb should be avoided? Reason being, these ketone bodies, they are mobilized to the liver, like acetate, acetoacetate or beta hydroxybutyrate. So they all go to the liver and they will be converted into endogenous bicarb. So we are getting bicarbonate endogenously. So there is no need to supplement it from outside. Otherwise, patient can go into alkalosis. So more the ketone bodies, more will be the production of endogenous bicarb in the liver. So high anion gap acidosis where there are metabolizable, remember, metabolizable unmeasured anions, usually unmeasured anions are metabolized into bicarb. So there is no need to replace it from outside. But still there are some indications of exogenous bicarb. There are two indications. One is dangerously low pH of less than 6.9, and secondly is hypotension despite IV fluids. Hypotension despite IV fluids, we give exogenous bicarb, because these ketone bodies now will not be mobilized to the liver because of hypotension, hypoperfusion. So we give bicarb from outside. And why not ringer lactate given? The question from Gorakhpur, why not ringer lactate is given. Remember, ringer lactate contain lactate, and this lactate is again converted in the liver into bicarb. So these ketone bodies, they are converted into bicarb. We are giving lactate, that is also converted into bicarb. So patient might land up into dangerous alkalosis. So remember, whenever there is high anion gap acidosis, lactate from outside, which is a source of potential bicarb, should be avoided. So if we are giving lactate, we will assume that we are giving bicarbonate to the patient, and hence instead of ringer lactate, normal saline should be given in a patient of diabetic ketoacidosis. Now coming to what is the role of bicarb in hypotension? There is no role of bicarbonate in hypotension. It means when there is a hypotension which is refractory to IV fluids, it means we are not able to establish the circulation. We are not able to bring ketones from the periphery into the liver, so they will not be metabolized. So patient will land up into acidosis. So we give exogenous bicarb. Normal value of bicarbonate, serum bicarbonate, normal range is 24 plus minus 24 is the normal limit, plus minus 2, plus minus 2. So 26 to 22 to 26, some books say 22 to 28 also, but for calculation point of view, and this of course is in millimoles per liter, or we can say milliequivalents per liter, same thing. Valency is 1, so millimoles is equal to milliequivalents. But for calculation point of view, we take 24 as a single point value for calculation as a normal bicarb, as a normal bicarb. Now coming to the management of starvation ketoacidosis and alcoholic ketoacidosis. Starvation ketoacidosis, the deficiency was of carbohydrate from outside, so we gave dextrose. So that will inhibit the underlying mechanism, that is gluconeogenesis, which was responsible for ketone body formation. Alcoholic ketoacidosis, here the treatment is supportive. We also give dextrose, mainly because patient is in hypoglycemia. Patient is in hypoglycemia, low sugar, so we give dextrose. But remember, dextrose should be supplemented with, in alcoholics, remember, any alcoholic patient, whether alcoholic cirrhosis, alcoholic liver disease, or acute alcoholic intoxication, if you are giving dextrose, supplement it with thiamine. Supplement it with thiamine. Reason being, there is a deficiency of thiamine in alcoholics, and dextrose for its metabolism uses thiamine. So whatever little bit of thiamine is left in the body, that will be used by dextrose for its metabolism. So what will happen? There will be a precipitation of acute thiamine deficiency, and that will cause Wernicke's encephalopathy. Wernicke's encephalopathy will be precipitated. So dextrose use thiamine, and whatever little thiamine is left, it is consumed, causing acute thiamine deficiency. So therefore we give thiamine with dextrose in any patient of alcoholic, if we are giving dextrose, Now coming to the this is ketoacidosis as a group. Now the second cause of high anion gap acidosis. So first we will finish the high anion gap acidosis. Can ultra short acting insulin can be given IV for ketoacidosis? Yes, we call this agent as insulin analogs, in which we do some modification in the amino acids, making it either very fast acting or sustained acting. So we can increase its action, we can make it very fast or we can make it slow. So insulin analogs which are ultra short acting, such as like any example, Lispro, Aspart, remember they can be given in IV infusion. They can be given in IV infusion, but they are not given. Reason being, they have same efficacy but high cost as compared with regular insulin. So ethically, regular insulin should be given because they have same efficacy and lower cost. Remember, these analogs are 3 times costlier than the regular insulin. So why to increase the cost of the patient when we are getting the same effect? Same effect. So though they are not contraindicated, but they are not given. Not given. Then what is the dose of thiamine? It is 100 milligrams. It is 100 milligram once a day will be the total dose of thiamine. And remember, thiamine is a water soluble. Even if there is a overdose issues, it will be excreted in the kidneys. So no as such problem in giving thiamine. So 100 milligrams per day. What about starvation ketoacidosis in diabetic patient? Dextrose or normal saline? No. Even in diabetic patient, if patient is not able to eat or take orally, dextrose should be given. Remember, do not give normal saline continuously to a patient of diabetic ketoacidosis. Afterward, change or add dextrose to prevent starvation ketoacidosis. And we are giving dextrose, and we are giving simultaneously IV insulin infusion also. So that will neutralize the sugars, that will neutralize the sugar. So dextrose, yes, it is given in diabetes starvation. If a diabetes patient has starvation, yes, dextrose should be given. And explain the lesions in Wernicke's reason. Remember, this will be a CNS topic, so it will take much longer time in Wernicke's. So if your CNS is not done, you can ask the sir to explain you about the Wernicke's lesion. That will be covered in CNS. Now coming to the second cause, that was lactic acidosis. So just in summary or revision, what we are doing? We are doing high anion gap acidosis. Number 1 was ketoacidosis. Ketoacidosis 3 causes: diabetic, starvation and alcoholic. Now the second group is lactic acidosis. So how does lactic acid increase in the body? Remember, as a basic, any molecule will increase in the body because of 2 reasons. First, synthesis is increased or catabolism is decreased. So lactic acidosis is due to either increased synthesis of lactic acid or a decrease catabolism So increased synthesis is because of anaerobic respiration. The product of anaerobic respiration we all know is lactic acid. This is known as type A lactic acidosis. Decreased catabolism occur under aerobic conditions. This is known as type B lactic acidosis. And remember, type A is more common than type B. Type A lactic acidosis more common than type B lactic acidosis. Now, what are the etiologies of increased synthesis? To understand it, we will again go to our basics and very basics. This is blood. This is the cell. And in cell, aerobic respiration occur inside mitochondria. So for aerobic respiration, what mitochondria need is the oxygen. So blood is supplying oxygen to the cells. So blood is perfusing the cell. There is a perfusion by blood, and hemoglobin gives oxygen to the cells, and aerobic respiration occurs. Aerobic respiration occurs. So perfusion of the blood, hemoglobin taking the oxygen from the lungs and giving it to the cells. So if this basic pathway is disturbed due to any reason, anaerobic respiration will take place, and that causes lactic acidosis. So number one cause, and this is the most common cause of lactic acidosis, is blood is not able to perfuse the cells. So if it is not able to perfuse the cells, cells will not get oxygen, and that is called as hypoperfusion. Hypoperfusion, which can be because of hypovolemic shock or which can be because of cardiogenic shock. Hypoperfusion of the cells. Then second, perfusion is alright, but the molecule which is taking oxygen from the lungs is deficient. So if hemoglobin is low, less oxygen will come to the cells. So severe anemia. Third, blood perfusion is alright, hemoglobin is alright, but there is a molecule which is dissociating oxygen from hemoglobin and attaching with hemoglobin itself. So oxygen is dissociated in the blood itself, so it is not carried to the cells. This condition is due to carbon monoxide poisoning. Now everything is fine, blood perfusion is alright, hemoglobin is alright, dissociation is alright, but mitochondrial enzymes are inhibited. So whatever oxygen is coming, no use, because enzymes are inhibited by the cyanide poisoning. Cyanide poisoning. So these are the four important causes of type A lactic acidosis. Type A lactic acidosis. Now coming to type B lactic acidosis, it is due to decreased catabolism. Decreased catabolism. And remember, lactic acid is catabolized in two organs, liver and some portion in kidneys, and it is metabolized into bicarb, we have seen. So if it is not able to catabolized into bicarb, it will increase in the blood. It will increase in the blood, and causes are obvious. Liver failure, second, kidney failure, third, and this is important one, drugs. So in discussing acid base balance, remember the pharmacology also. That means drugs causing individual acid base imbalance. So here drugs are causing high anion gap acidosis by causing lactic acidosis, and important drugs are, we have seen, are biguanides. Example is metformin, INH, antitubercular drug, then zidovudine, antiretroviral therapy against HIV, that has the predisposition to cause impaired metabolism of lactic acid, causing lactic acidosis, and also some toxins like ethanol, and methanol. Ethanol and methanol, they impair lactic acid utilization, leading to lactic acidosis. So these will be the aerobic, or we can say type B lactic acidosis causes. Then coming to the treatment of lactic acidosis. Treatment is number one and most important is treatment of underlying cause. For example, most common cause are hypoperfusion, and hypoperfusion is mainly because of hypovolemia. So if it is hypovolemia, we have to give IV fluids, and which IV fluid we will choose? We will choose IV normal saline, and again not Ringer lactate. Remember, if it is causing lactic acidosis, reason we have discussed, lactate will make bicarbonate. So during the recovery phase, alkalosis can occur. And second important concept in treatment, many times this question has come, old MCQ, is the target pH. We have seen the normal range of pH is 7.34 to 7.44. We will not make the pH in this range. The pH we will is 7.20. So repetition is ki we treat underlying cause, and if it is hypovolemia we give IV normal saline, not Ringer lactate, because this lactate will be converted into bicarbonate. So this is exogenous lactate and there will be endogenous lactate. So both will be converted into bicarb. Patient will end up into alkalosis. So we will not give Ringer lactate. So target pH should be 7.20, though the normal range is this. Reason is simple. When we are treating a patient, lactate will be converted into bicarb. So we make the pH as 7.2, and this bicarb will be endogenous bicarb from endogenous lactate in the liver. So what will happen? This bicarb which is produced will further increase the pH to bring it in the normal range. It might take a few hours to 1 or 2 days. So leave the pH as 7.2. Rest work will be done by conversion of lactate, endogenous lactate into endogenous bicarb. So it will increase the pH to say 0.20, and patient will have a pH of 7.40, which is normal. So there will be an addition of bicarb. Remember, during recovery period. Suppose you have brought the pH to 7.40, say. Endogenous bicarb will be produced. They will further elevate it to 0.2, 7.60. So patient will be in great trouble. He will be in alkalosis. So never make the pH as normal, because during recovery phase bicarb will be produced and they will automatically increase the pH to 7.40. Now the third cause of high anion gap acidosis, it was drug induced or toxins. So here first is salicylic overdose. overdose. So that will bring salicylic acid will bring with it salicylate, and that causes high anion gap acidosis. But the questions which are important is the what are the manifestations of salicylate overdose? Manifestations. So the patient is consuming salicylic acid orally. Orally. So that will irritate the stomach. Irritate the stomach, and that will cause gastritis. So manifestation will be gastritis. That leads to usually vomiting episodes, and in vomiting there is lots of HCl, which is acid, is lost outside the body. HCl loss. So gastritis, vomiting, acid loss. So in the body what will happen? Body will go into metabolic alkalosis. Metabolic alkalosis. So question is, seizures causes lactic acidosis. Seizures typically lead to rhabdomyolysis if they are prolonged seizures, and rhabdomyolysis causes myoglobinuria, which is a cause of, we can say, acidosis, which we can say as acidosis, not particularly lactic acidosis, not particularly lactic acidosis. So gastritis, vomiting, acid loss leading to metabolic alkalosis. Secondly, this salicylate, salicylic acid, will be absorbed into the blood. It will be absorbed into the blood, and in the blood bicarb will bind with acid component and salicylate will become free. So it will cause high anion gap metabolic acidosis. So in blood salicylate will increase. So high anion gap metabolic acidosis. Third is, and a very important, this salicylate, it is independently causing stimulation of respiratory centers. Salicylate independently stimulate respiratory center. Independently means over and above the compensatory response of metabolic acidosis. Metabolic acidosis also stimulate respiratory center, no doubt about it, but salicylate independently can stimulate respiratory centers independently. So what will happen? There will be respiratory center stimulation leading to hyperventilation, and hyperventilation is responsible for respiratory alkalosis. Respiratory alkalosis. So in summary, if we'll see what are the disorders which can occur because of salicylate overdose, it is metabolic alkalosis, high anion gap metabolic acidosis, and respiratory alkalosis. Respiratory alkalosis. So the disorder which is not seen is respiratory acidosis in salicylate overdose. Salicylate overdose. Now coming to the treatment of salicylic acid overdose. Remember, there is no specific antidote for salicylic acid, so we go for rice tube lavage. Then we give patient IV fluids, and the basic component of these IV fluid is we add dextrose. We add dextrose because these patients are at risk of hypoglycemia. They are at risk of hypoglycemia. Reason being, these patients, they are vomiting, plus there is a sort of liver damage by salicylic acid. So whenever this combination comes, vomiting plus liver damage, it will have a tendency to cause hypoglycemia, because if patient is vomiting, gluconeogenesis, which mainly takes place in liver, will not occur and hypoglycemia will be the manifestation. Third is, if patient is not improving, then we go for hemodialysis. Hemodialysis. Now, the second drug overdose or toxin induced. So first we have done is salicylic acid. Second is methanol poisoning. Methanol poisoning. This is a toxin. This is toxin. So this category is drug induced or toxin. First is salicylate, second is methanol poisoning. So methanol is converted with the help of alcoholic dehydrogenase into formaldehyde, and this by aldehyde dehydrogenase is converted into formic acid. Formic acid. So methanol, alcohol dehydrogenase, formaldehyde, aldehyde dehydrogenase, formaldehyde is converted into formic acid. Now, this formic acid is a toxic compound. It causes optic neuritis, directly damages the optic nerve. Secondly, it is responsible for, means it is giving acid, so high anion gap metabolic acidosis. High anion gap metabolic acidosis. So what will happen? Bicarb will bind with the acid and it will leave behind formate. Formate is unmeasured anion. So we will get high anion gap, and because bicarbonate is becoming deficient, metabolic acidosis. So this is a unique combination of optic neuritis plus high anion gap metabolic acidosis. So answer will be methanol poisoning. Methanol poisoning. So what will be the treatment? Treatment is we have to decrease the conversion of formic acid. Formic acid. So how does we decrease the conversion to formic acid? Because this is the toxic compound. This is the toxic compound. So we will act on step number 1, which is alcohol dehydrogenase. So we will take this enzyme in the metabolism of certain other chemicals, and the product will be non-toxic. Remember, the product should be non-toxic, therefore we use that product, and it is foamy Fomepizole. Fomepizole. So, how formic acid causes optic neuritis? It causes axonal damage. It causes formate damages the axons of the optic nerve, and the phenomena is retro orbital, means ki it is behind the orbit. It is behind the orbit, so it is axonal damage by formate. Axonal damage by formate, which is responsible for optic neuritis. Optic neuritis. So alcohol dehydrogenase will metabolize fomepizole into a non-toxic product, or secondly we can use ethanol also. Ethanol also. So which will be the better drug? Will it be fomepizole or ethanol? Any one of you? Drug of choice out of fomepizole and ethanol. Answer is antidote is ethanol, fomepizole, ethanol. So there are more votes going in favor of ethanol, but the drug of choice is fomepizole. Is fomepizole. Reason being, ethanol by itself causes drowsiness, and if it is causing drowsiness, hyperventilation, which is a compensatory mechanism, will go down. So ethanol in most of the individuals except few, it causes drowsiness. It makes some few alert, but most it causes drowsiness, and drowsiness is there, hyperventilation will decrease, and remember hyperventilation was a compensatory mechanism. So you are decreasing the compensatory mechanism of metabolic acidosis, so patient can land up into dangerous acidosis even after treatment. So this should be avoided, and it is given because most of the centers fomepizole is not available, so that is the indication by why we are giving ethanol. Then the third toxin or drug overdose is ethylene glycol. And where it is used in cars as anti-freezing agent. So why does patient consume ethylene glycol? Because it tastes as ethanol, it tastes as alcohol. So patient do not have money to buy ethanol, so he will go to the car, take a straw and will suck this ethylene glycol, which is used as a anti-freezing agent. So both foamy and ethanol antidote, yes, we can say both are antidote. So this is converted by alcohol dehydrogenase into oxalic acid, and this oxalic acid, it causes acute tubular necrosis, as well as it is a source of acidosis as well as high anion gap metabolic acidosis. So this combination, acute tubular necrosis plus high anion gap metabolic acidosis, is usually due to oxalic acid, which is produced from the metabolism of ethylene glycol. So the toxic product is oxalic acid. Treatment is same. It means either we can give fomepizole or we can give ethanol. We can give ethanol. Now the final cause of high anion gap acidosis. So summary: high anion gap acidosis is because of ketoacidosis, lactic acidosis, drug or toxin induced, and finally it is accumulation of sulfate and phosphate, which is due to renal failure. So here just only one point to remember: renal failure we will do in the nephrology section, that there is a decreased excretion of sulfate and phosphate if GFR is less than 20 ml per minute. So when it is reduced to 20 ml per minute, then we will have a decreased excretion of sulfate and phosphate that are responsible for the high anion gap acidosis. High anion gap acidosis. So we'll take a break, and after break we will continue with non-anion gap acidosis. Non-anion gap acidosis. So we have done the high anion gap acidosis condition. So before going to non-anion gap, let's see what will be the causes of low anion gap states. That will occur when there is a decrease in unmeasured anions or an increase in unmeasured cations. Or decrease in or increase in unmeasured cations. So the decrease in unmeasured cation will be for those conditions which are physiological. So we have seen the physiological was albumin. So if albumin decreases, there will be low anion gap state, and we all know that albumin is the major protein. So hypoproteinemia minus increase in unmeasured cations. Please repeat the RF. What is RF? So increase in unmeasured cations will be like high calcium, high magnesium, high potassium, lithium, lithium toxicity, immunoglobulins high, immunoglobulins high. So renal failure is when the GFR is less than 20, there will be accumulation of sulfate and phosphate that causes high anion gap acidosis. So these are the conditions which are responsible for low anion gap states, that if decrease in unmeasured anion, which is albumin, decreased, it will cause low anion gap state. Unmeasured cations increase like calcium, magnesium, potassium, lithium toxicity, or immunoglobulins which are positively charged, though they are responsible for low anion gap states. And in questions, usually they do not give the low albumin, they do not give the high immunoglobulins, they will give the etiologies. So etiology of low albumin, they will give like nephrotic syndrome. So nephrotic syndrome is a low anion gap state, low anion gap state. Immunoglobulin high, they will give you multiple myeloma. High lithium, they will give you lithium toxicity. So these will be the major and important condition of low anion gap states. Now coming to so we have done low anion gap states, low anion gap state which can occur if unmeasured anions become decreased low or unmeasured cations they become high or increased. So low unmeasured anion will be albumin. We have done the list of unmeasured anion in which the physiological was albumin. So if it is decreasing like in nephrotic syndrome, anion gap will be low. While increased in unmeasured cations will cause low anion gap states, and that will be high calcium, high magnesium, high potassium, lithium high or immunoglobulins high. They all causes high unmeasured cations responsible for a decreased gap. And bracket is the clinical conditions which give rise to high lithium, that is lithium toxicity. Immunoglobulins positively charged, they are high in cases of multiple myeloma. So these are the low anion gap states, low anion gap states. Now coming to non anion gap metabolic acidosis. So it is basically grouped into causes. Two main category. One is and here there is as such no production or no addition of acid. It is basically because of loss of bicarbonate from the body or retention of H ions in the body, retention or loss of bicarb from the body. So we can say that there is a bicarbonate loss or decrease H plus excretion. These normal H ions are not able to excrete it from the body. So this bicarb loss can be GIT loss. So causes are bicarb losing diarrheas, then it can be because of bicarb lost from the pancreas. Pancreas is a major organ which synthesizes bicarbonate so that its enzyme can work there. So if there is a pancreatic fistula, so all the bicarbonate will be drained out from the body, And third GIT loss is use of anti-acid preparations like magnesium hydroxide. So here we know there is loss of bicarbonate, so bicarbonate deficiency, pancreatic fistula, loss of pancreatic bicarb. So how does antacid intake leads to bicarbonate loss, So this is because of, like a patient is taking magnesium hydroxide, so it goes in the intestine, pancreas will release bicarb, normally whatever bicarb is being released by pancreas, they are normally absorbed from the intestine, So there is a replenishment of bicarbonate in the body. But when a patient is taking magnesium hydroxide, so what will happen? This bicarbonate, they bind with positively charged magnesium, and this magnesium bicarbonate complex, this complex will be lost in stools. So this complex is not able to absorb. So in a sense, the bicarbonate, they are attached with magnesium, and then they are lost in the stools. So normal absorption will not take place, and body become deficient in bicarbonate. Body is deficient in bicarbonate, causing metabolic acidosis. So very important disorder is use of these antacids. Now the second category was this was the GIT causes. Three causes we have done: bicarb losing diarrheas, pancreatic fistulas, and third is the drugs. Now renal cause. So when there is renal failure, but when the GFR is in the range of 20 to 50 milliliters per minute, this GFR 20 to 50 ml per minute, it is responsible for tubular dysfunctions. And we have seen one of the main important role of proximal tubule is to absorb bicarb. So if that tubule is not working properly, bicarb will be lost. Secondly, renal cause is renal tubular acidosis. So the exact pathogenesis we will study in the kidney. Kidney section. But for the time being, just remember, renal tubular acidosis is due to primary disorders of the tubules. Like we have seen, one was proximal tubule, second was distal tubule. Proximal tubule function was to absorb bicarbonate. So if this tubule dysfunction occur primarily, this channel is not working. So bicarb will be lost in the urine. It will be lost in the urine. So metabolic acidosis. Distal tubule was releasing H ions normally. So if there is a dysfunction of this channel, H ion will not be excreted from the body. They will retain in the blood. Causing metabolic acidosis. So failure of H ion excretion or bicarbonate loss is the reason for renal tubular acidosis to be labeled as a metabolic acidosis, and that will be non-anion gap. So these are the two causes in the kidney. Renal failure when GFR is 20 to 50. We have seen when the GFR is less than 20, it was a high anion gap acidosis. But with this GFR, it is non-anion gap acidosis and renal tubular acidosis. So there is a question frequently asked is, how will we differentiate between a GIT cause and a renal cause of metabolic acidosis. So differentiate between GIT and renal cause. So diarrhea non-anionic means ki non-anionic. Remember, diarrhea is a non-specific term. If it is bicarb losing diarrheas, it will be metabolic acidosis, non-anion gap. But if it is plain diarrhea, it causes metabolic alkalosis. Metabolic alkalosis. So that we will see, if only diarrhea is written, it will be metabolic alkalosis. But if it is specified bicarb losing diarrhea, it will be metabolic acidosis. So how to differentiate these two conditions, that metabolic acidosis is due to GIT source or because of renal source? And the answer is urinary anion gap. So this is the second gap which has come, gap, urinary anion gap. So first we'll see how to calculate the urinary anion gap, and then we will see how we can differentiate these two reasons. So urinary anion gap is same. It is the difference between unmeasured urine anions. So after renal tubular acidosis, we have done we haven't done anything. So we have just discussing after renal tubular acidosis how to differentiate between GIT and renal cause of metabolic acidosis. So that is done on the basis of this concept of urinary anion gap. And a few questions have come from this portion, urinary anion gap. So let's understand what is the meaning. Urinary anion gap is the same as difference of unmeasured urine anions minus unmeasured urine cations. So we are measuring these ions in the urine. So it is similar to serum anion gap, but with few differences. So let's understand. Then in urine, total anions are equal to total cations. This holds true for urine also. So total we can split. It can be split into measured anions plus unmeasured anions. These all are in the urine. Total cations we can split measured cations plus unmeasured cations. Now the measured anions in the urine, they are chloride. Measured anion. Reason being, bicarbonate normally is absorbed through proximal tubule, that we have done in the earlier sections. Bicarbonate is absorbed through proximal tubules. 90% or more than 90%. So its excretion normally is very less in the urine. Then unmeasured anions equal to. Now let's see what are the measured cations. Here sodium will be positive. Urine is acidic. How total anions are equal to total cations? Remember, this is a very basic concept. Acidity and alkalosis, they are not equivalent to anions or cations. Anions or cations is electroneutrality. Electroneutrality. While pH is a separate thing. pH is a separate thing. So do not confuse between electroneutrality and the pH. So in urine, total minus will be equal to total positive. Total positive. Acidity alkaline urine is a totally different thing, unrelated to anions or cations. So major cation will be sodium plus. Here we will get potassium. Why we are getting potassium in the urine? Reason, because of aldosterone. Because of aldosterone. Aldosterone is absorbing sodium, but it is also excreting potassium also. It is excreting potassium also. So sodium and potassium is a measured cation plus unmeasured cations. Unmeasured cation. So what we'll need? Unmeasured anions minus unmeasured cations. So we'll take this left side. Chloride will take it on the right hand side. So unmeasured anions minus unmeasured cations is equal to sodium plus potassium minus chloride. So this is the formula of urinary anion gap, and the normal value is almost equal to 0. Almost equal to 0. That means the total unmeasured anions are approximately equal to total unmeasured cations. When we'll do the example of unmeasured anions in the urine, it is bicarbonate. Example of unmeasured cation is NH4 plus. NH4 plus. So on the basis of this, let's see how urinary anion gap will change. It can change in two directions. Value can be less than 0, where it is called as negative urinary anion gap. Value can be more than 0, where it is called as positive urinary anion gap. So urinary anion gap abnormalities are either negative or positive So let's see what will happen in cases of GIT cause. GIT cause of metabolic acidosis. Let's see. And when we'll say that it is a GIT cause, we will assume that kidneys are normally functioning. They are normally compensating. So when there is a GIT cause of metabolic acidosis, urinary anion gap, which is equal to unmeasured anions minus unmeasured cations. Example was bicarbonate. Example was ammonia. So kidneys are normally functioning. There is a acidic pH in the blood, and this we have discussed earlier also, that if there is a low pH, kidneys are normally compensating. What will happen to urinary bicarbonate? Urinary bicarbonate. Kidneys, they will be absorbing bicarb as a compensatory response. So bicarbonate value decreases. Minus. What will happen to ammonium ion if there is a acidosis in the blood? This NH plus will increase. This we have done earlier. So let's see If unmeasured anion is decreasing, unmeasured cation is increasing, what will happen to urinary anion gap? Urinary anion gap become, normal was 0, so it become less than 0. It become negative. It become negative. So best way to remember is when there is a GIT cause of metabolic acidosis, urinary anion gap is negative. Gut cause negative. Gut cause negative. So let's see, when there is a GIT cause, kidneys are normally functioning, tubules are normally functioning. So there is a acidosis in the blood, acidosis in the blood, and we have seen in our today's earlier discussion that this is proximal tubule. If there is a low pH in the blood due to GIT cause, bicarbonate absorption increases. If bicarb absorption increases, its excretion in the urine decreases. So urinary bicarb is low because it will be absorbed much more than the normal value. Also, when there is a acidosis in the blood, that is low pH, distal tubule, they will excrete more H plus, and proximal tubule they will excrete ammonia. So ammonia increase, H plus increase when there is a low pH in the blood. As a result, urinary NH4 increases when there is a low pH in the blood. This we have already discussed in the initial part of acid base compensation. Acid base compensation. So NH4 increases in the urine. These are the urinary findings. Urinary findings. So this gap become negative, and best way to remember is gut. Gut is GIT negative, urinary anion gap. When it is a renal cause of metabolic acidosis. So let's see what will happen. Kidneys are involved. So kidneys are involved. Basically it will be a tubular disorder which is causing a metabolic acidosis. So urinary anion gap, what will happen? So unmeasured anion, which is bicarbonate, minus unmeasured cations, which is ammonia. So let's see, if this channel is not working, tubular dysfunction, bicarb is not absorbed into the blood, and that is a reason for low pH. So bicarbonate concentration in the urine increases. So bicarb increases in the urine. While if distal tubule is not functioning, there will be less excretion of H-ion, and proximal tubule is not working, less excretion of ammonia. So these tubules are not functioning properly. As a result, NH4 plus decreases in the urine. So distal tubule not working, H-ion not excreting out. If H-ion is not excreting out, obviously NH4 will be less in the urine. So it is less. So unmeasured anions are increasing, unmeasured cations are decreasing. The gap, urinary anion gap, will be more than 0, which we call it as positive. So this is the difference. Urinary anion gap positive in renal cause, it is negative in GIT cause. in GIT cause. So importance of urinary anion gap. Now there are some miscellaneous cause also of non anion gap metabolic acidosis. We have done two. One was the GIT cause, second was the renal cause. So miscellaneous cause mainly is the drug. So another pharmacological reason for a non-anion gap metabolic acidosis. Drugs are those drugs which are causing hyperkalemia, So how does that lead to acidosis? Remember, if there is increased potassium in the blood, and this is the cells, so increased potassium, main risk is it causes cardiac arrhythmias. Which is very dangerous for the body. So body will not go into that state. High potassium, it is exchanged, means it goes inside the cells. So cells will take up potassium, but instead they release H plus. So this is an exchange. If potassium is high, it will enter into the cells. Inside, electron neutral environment can be disturbed. So to maintain it, one positive positive will go out, mostly in the form of H plus. So H plus increases, and we all know H plus increases, that means there is metabolic acidosis. So what are those drugs? We all know that common drugs which causes hyperkalemia is ACE inhibitors, ARBs, then potassium sparing diuretics, then trimethoprim, it is antibiotic which decreases potassium excretion and hence metabolic acidosis. Pentamidine, it causes cytolysis of cells. So whatever cells pentamidine is affecting, intracellular potassium moves into the blood and it causes hyperkalemia. So remember these two more important drugs, usually antimicrobial drugs with the side effect of metabolic acidosis. So the treatment is the treatment of underlying disorder, whether it is GIT, kidneys or drugs, removal of the offending agent. Then these were the metabolic acidosis. Coming to the next disorder, which is metabolic alkalosis. So by convention we divide metabolic alkalosis into two groups. And these two groups are chloride responsive and second is chloride unresponsive. So how does that classification comes into effect? Insulin also drags potassium inside cells. It causes metabolic acidosis. No, it causes hypokalemia instead. Insulin causes hypokalemia, not hyperkalemia, not hyperkalemia. So it will be not a cause of metabolic acidosis, not a cause of metabolic acidosis. Now, metabolic alkalosis divide into chloride responsive and chloride unresponsive. So let's see what is the mechanism and how this classification comes into effect. So the mechanism in chloride responsive is chloride loss. There is a chloride loss from the body. So body will become deficient in negative charge, and to maintain electroneutral environment. Remember, first priority of the body is to make electroneutrality, maybe at the expense of acid base disorder. So how it will make body electroneutral? If there is a chloride loss, it will gain one negative charge. So if there is a one negative charge loss, it will gain one negative charge, mostly through kidneys or intestine. So it will absorb more and more of bicarb. So bicarb reabsorption increases. But secondary to chloride loss, remember, this is the main pathogenesis, that chloride loss stimulate bicarb reabsorption. So there is more and more of bicarb in the body, and if there is more bicarb in the body, metabolic alkalosis. So why we have classified into chloride responsive? We have classified into chloride responsive because if we replace chloride loss, that stimulus will go, and after replacing chloride, metabolic alkalosis will improve, will be recovered, we can say. So only treatment needed will be chloride supplement. So when we supplement the chloride, there will be no burden of bicarb reabsorption. So bicarb reabsorption will stop, and that will improve or recover the metabolic alkalosis. So treatment is chloride replacement. So let's see what are the causes. Then we move to chloride unresponsive. Causes or etiologies are: first, chloride loss can occur through vomiting. There is also associated loss of the acid and there is also volume depletion, but these are secondary effects. Main is the chloride loss through vomiting. Second, diarrhea, and these diarrheas are known as chloride losing diarrheas, if it is specifically mentioned, chloride losing diarrheas. Then the chloride loss can be from kidneys also. Renal loss. How does renal loss? When patient is taking diuretics. So there will be a renal loss of chloride. Then sweat loss. Chloride are lost in the sweat. Which disorder? Anyone? Sweat loss of chloride is important cause of metabolic alkalosis. Metabolic alkalosis. Yes, this is cystic fibrosis. Yes, very good. So, remember the causes of chloride loss? They will be metabolic alkalosis. Metabolic alkalosis through chloride loss. And when we supplement chloride, metabolic alkalosis will be recovered. So we'll do the treatment simultaneously. Treatment is chloride replacement in the form of either sodium chloride, potassium chloride. We can give. So chloride is being replaced. That will take care of metabolic alkalosis due to these four important causes. Now, what about this disorder? Chloride unresponsive. Chloride unresponsive, as the name suggests, that if we replace chloride, it will not recover because the pathogenesis is different. Pathogenesis is totally different. So the mechanism here is increase aldosterone or increase aldosterone like activity. So here there is no relation with the chloride loss. So high aldosterone or aldosterone like activity is responsible for this type of metabolic alkalosis. Let's see how, with the help of a diagram. This is the principal cell where aldosterone is working. This is the luminal side, this is the blood side. So function of aldosterone is primary function is it absorbs sodium. So when it is working more, aldosterone, it will absorb more sodium than the normal. It will try to absorb more sodium than the normal. So what will happen to the charge in the lumen? Lumen become negatively charged, more negatively charged, because sodium, which is a positive ion, is absorbed more than the normal. So to compensate for this charge, two things will go, and there are two electrolytes which will go. One will be, of course, potassium. So more the sodium absorption, more potassium will go. Also H plus. These are the two positive charge which will go outside in response to aldosterone activity. So what will happen? Body is losing potassium. So all these states will be a hypokalemic state, and all these state will lose H ion. So there will be H ion deficiency, which is the reason for metabolic alkalosis. So in summary, these chloride unresponsive causes of metabolic alkalosis, they have a common feature of hypokalemia, is seen in this disorder. So potassium is lost, H ion is lost. So now let's see what are the etiologies. Of chloride unresponsive. So chloride unresponsive, we can further divide according to a one important clinical feature, and remember that is a very important clinical feature. You should read it very carefully in the question, that will narrow down your differential diagnosis of metabolic alkalosis. It is divided into two groups: chloride unresponsive, where blood pressure is high or blood pressure is low or normal. Two groups. So let's see what are the causes where BP is high. Chloride unresponsive. Number one, we have seen increase aldosterone will cause metabolic alkalosis. So aldosterone is high primarily because adrenal is working more autonomously, and this is known as primary hyperaldosteronism. So in this disorder, as a group, primary hyperaldosteronism, examples include Conn's syndrome, example is Conn's syndrome, then Cushing syndrome, then neoplasias of adrenal. So these all are responsible for metabolic alkalosis. Then second, aldosterone can be high because it is getting a stimulus from renin. So high renin states, and these high renin states are renin tumors, because renin stimulate aldosterone. So if renin is high, aldosterone will be high. Or it can be renal artery stenosis, So remember, high renin states, they all lead to metabolic alkalosis. Now third is, this is not a hyperaldosteronism state, but a aldosterone like activity, and that is known as Liddle's syndrome. So what exactly is the Liddle syndrome? It is activating mutation of E sodium channel. Activating mutation of E sodium channel. Remember, not all mutations are inhibitory mutations. Some are activating mutations also. That means that channel is working more. This is a gain of function. So what will happen? This E sodium channel, remember, is the same channel where aldosterone is working. So if this channel become hyper, E sodium channel, so from the lumen it will absorb more sodium and more of potassium and hydrogen ion. They will move, so their excretion increases, because this is a gain of function. This is working more, so what will happen? That when sodium is absorbed in the blood, more sodium primarily, it will cause high blood pressure. So this is a high BP condition, included in high BP condition, Liddle's syndrome. And potassium moves out, hypokalemia. H ion moves out, metabolic acidosis, metabolic alkalosis. H ion is moved out. So this is E sodium channel. E means epithelial sodium channel, and this is the same channel where aldosterone is working. So this is a high, we can say, aldosterone-like activity. Aldosterone-like activity is occurring here. So what is the treatment of this disorder? Remember, treatment of this disorder will be inhibit E sodium channel. And remember, this is not spironolactone, because spironolactone is against aldosterone. So the medicine which specifically inhibit this channel, and that is the treatment of choice, that is amiloride. So drug of choice, Liddle syndrome, amiloride. That will take care of metabolic alkalosis also. Are these E channel normally functional? Yes, these are normally functional, means aldosterone is working on these channel and causing the sodium absorption. So these are normally functioning. So this is overactivity of this channel. Now coming to the second group of we can say the BP was normal or it was low. BP is normal or low, and included in this disorder is the two congenital syndromes, and these are Bartter syndrome and Gitelman syndrome. So basically these two syndromes, what is the basic pathophysiology mechanism? So if we look at the kidney tubules, this is a kidney tubule. This is loop of Henle, thick segment, PCT, thick segment. So here are the channels, sodium channel. In the thick segment of loop of Henle, we have a channel known as sodium potassium 2 chloride channel. The function of this channel is that it absorbs sodium and potassium. Along with that, 2 molecules of chloride are also absorbed. This is a normal function of this channel. Suppose if there is a inhibitory mutation of this channel, Remember, inhibitory mutation. What will happen? There will be a predominantly sodium loss. So sodium is not able to absorb, sodium loss will occur. And remember, sodium does not move alone out. There will be a water loss also. And when there is a water loss, there will be renin stimulation. Renin stimulation. So whenever there is a water loss, there is a hypovolemia in the blood. Hypovolemia in the blood. So renin is stimulated, but as a compensatory mechanism. But as a compensatory mechanism. So sodium loss, water loss, renin will increase, and this renin increase will cause aldosterone high. Aldosterone high. Hence, there will be increased aldosterone activity, which will try to absorb sodium, but in exchange it will release more of potassium, more of H ion in the lumen. So body will become alkalosis. There will be a alkalosis in the body. This mutation is the characteristic mutation of Bartter syndrome. So there is inhibitory mutation of sodium potassium 2 chloride channel in Bartter syndrome. In Bartter syndrome, remember, inhibitory, loss of function. While in Gitelman, what happens, there are channels in the PCT, and this is sodium chloride channel. Function is same. This absorb sodium and this absorb chloride. So if there is a inhibitory mutation, same, sodium loss will occur. And hence water loss, and hence renin high, aldosterone high. So Gitelman syndrome is due to inhibitory mutation of sodium chloride channel. Inhibitory mutation of sodium chloride channel, responsible for metabolic alkalosis. So these are the two main congenital syndromes, Bartter's and Gitelman's, responsible for a normal to low blood pressure. And these will also discuss in detail when we will do the tubular dysfunctions of kidney, ki what is the difference between these two, what is the management of these two syndromes. Then this was the classification of metabolic alkalosis into chloride responsive and chloride unresponsive. There are some miscellaneous causes also. Miscellaneous causes of metabolic alkalosis. Why BP is normal? BP is normal too low because aldosterone is compensatory high. Aldosterone will be able to absorb sodium and it is able to maintain a BP as normal, low normal. So BP remains normal, or we can say low normal in this condition due to the effect of aldosterone. And remember, this is also known as secondary hyperaldosteronism. So miscellaneous cause of metabolic alkalosis are there can be exogenous bicarbonate load. Means patient is consuming alkali from outside. So why patient is consuming alkali from outside? This is a syndrome, characteristic syndrome known as milk alkali syndrome. milk alkali syndrome. So what happens? The clinical case is a classical history of gastritis or peptic ulcer. Or peptic ulcer. So Bartter syndrome, chloride ion increase or decrease, this will be lost in the urine. It is same for Bartter, it will same for Gitelman. So they are continuously lost from the body, So why it is chloride unresponsive? Because whatever chloride you are giving, it is lost through the urine. So the defect is we can say a severe defect. So we in Bartter syndrome, chloride ions are lost through the urine. History of gastritis or peptic ulcer, and patient will be taking to control these chronic gastritis or peptic ulcer, patient will be consuming alkali therapy, and this alkali therapy is responsible for metabolic alkalosis. So this is a exogenous alkali. Like you must have heard in the advertisement. The patient is the advertisement is ENO. ENO is a very popular alkali therapy, exogenous alkali therapy. They say ENO on acidity gone. Now patient is also taking milk, because milk is supposed to neutralize the acid of stomach. So patient will develop hypercalcemia. And hypercalcemia, it has a property that it causes renal vasoconstriction. Leading to renal failure. GFR will reduce if there is a renal vasoconstriction. So third component is renal failure. So let's see what are the components of milk alkali syndrome. First, metabolic alkalosis. Second is hypercalcemia. Third is renal failure. So this defines the milk alkali syndrome. And when this renal failure becomes irreversible, it is known as Burnet syndrome. Again, important question. So remember, never advise a patient to take ENO. ENO contain bicarb, it can cause metabolic alkalosis. Also, ENO contains sodium also, soda bicarb. So never advise a patient to take ENO, because sodium will also be increased in the body, and especially hypertensive patient, BP can be high, and this high BP can lead to hemorrhagic stroke. So never ever recommend your patient ENO that causes high BP, especially in already a hypertensive patient, and that can cause hemorrhagic stroke. So ENO on acidity gone, also patient gone. So avoid ENO. Now coming to treatment in cases of Bartter and Gitelman. Actually this will do in the kidney topic separately when we will do the tubular disorders. Now respiratory This was metabolic alkalosis, the causes and the treatment in those cases. So respiratory acidosis, next disorder. So respiratory acidosis, in one word we'll say that there is a accumulation of PaCO2. PaCO2 is high. This is because of ventilation is not proper. So hypoventilation. Because in physiology we have understood that ventilation, the primary is the CO2 exchange. Oxygen is also a part of ventilation, but out of oxygen and CO2, main is the CO2 excretion. So if there is a hypoventilation, CO2 will increase. CO2 will increase. So it is also known as type 2 respiratory failure. So high PaCO2 which is increasing due to hypoventilation is known as type 2 respiratory failure. So whatever causes we will do here. Okay, Burnett syndrome is if renal failure of milk alkali syndrome become irreversible. That is known as Burnett syndrome. So type 2 respiratory failure, whatever causes we'll do here will all be the causes of type 2 respiratory failure. So that will cover yours a little bit of respiratory failure from this section. So to understand it, let's see what are the factors which determine the ventilation. So how does ventilation occur in the body? It has got a pathway. So this is the site and these are the causes. So the impulse for ventilation arises in the brain, we all know, and this is respiratory centers. So this is the initial point in the brain, respiratory center, and they are located near the medullary part of brain, near the medulla. So if anything is inhibiting the respiratory center, ventilation will not take place. So respiratory centers are inhibited by drugs, so drugs which inhibit the respiratory centers, they are morphine, they are benzodiazepines, then respiratory center can also be inhibited if it is not getting the blood supply because of stroke. Or respiratory center, they are lazy, they are not releasing the impulse. This is a peculiar syndrome known as central hypoventilation syndrome. And remember that we'll do in the respiratory section also. Then from respiratory centers, impulse then goes down and it moves down through spinal cord. And we know that spinal cord, there are three segments where it is going. So C1, C2, C3, C4, C5, C6. So impulse is coming from the brain through spinal cord like this. Like this. And from the root value of C3, C4, C5, it is making a nerve known as phrenic nerve. So we know the main muscle of respiration is diaphragm. So the main nerve of respiration, main nerve is phrenic nerve. So through spinal cord, it is making through C3, C4 and C5 the phrenic nerve. So if spinal cord is damaged, there will be a damage of phrenic nerve also. So respiratory failure. So where exactly will be the lesion that causes the damage of phrenic nerve? Remember, this damage can be C3. If it is at C3 level, so C3 will be gone and below everything will be gone. So C4 will be gone, C5 will be gone, hence whole phrenic nerve will be gone. If lesion is at C2, that will also cause loss of C3, C4, C5. C1, loss of the lower nerve roots, so also affect the phrenic nerve. So remember, the lesion in spinal cord will be at C3 or above. At C3 or above. If transaction is here or here or here, lower part will be gone, which is phrenic nerve will be gone. So lesion should be at C3 or above. This lesion's example can be trauma. Remember, in any road traffic accident, the main priority will be stabilize the spinal cord. If there is a trauma or a fracture, it can cut the nerve completely. So whether you do ABC, whether you do CAB, nothing will be beneficial because you have damaged the nerve completely. So the first priority is stabilization of cervical spine. So trauma, it can be polio, because polio, what it is causing? It is causing the damage to motor neurons. Damage. So remember, this is frequently asked in the questions, options. Causes of type 2 respiratory failure, they will give polio as the option. Yes, it is true, by causing motor neuron damage. Then it can be amyotrophic lateral sclerosis, again by damaging the motor neurons. Now the impulse will go through the nerve. Example or causes will be neuropathy. And important neuropathy causing respiratory failure is Guillain-Barré syndrome. And this is also frequently given in the option of type 2 respiratory failure. Then from nerves, impulse then goes to neuromuscular junction. Neuromuscular junction can be presynaptic, and the cause here will be Lambert-Eaton syndrome. Or it can be post-synaptic. It is myasthenia gravis. Then the impulse goes to muscle, and we all know that it is a diaphragm. And the cause is myopathies. And this include common myopathy or dystrophies, to be more precise, Duchenne muscle dystrophies or Becker muscle dystrophy, muscles. Then the next pathway which comes is chest wall. So chest wall should move for ventilation, means it should expand, it should retract, so that ventilation should be proper. So the chest wall disorders which decreases this flexibility of movement, they are chest wall, which are causing the stiffness of chest wall, ankylosing spondylitis, a very important option given in the question as a cause of type 2 respiratory failure. Then chest wall deformities which impact the full movement, it is kyphoscoliosis. So these are the chest wall movements, chest wall disorder which leads to type 2 respiratory failure. Because of stiffness of the chest. Then of course if there is airways which are chronically damaged, so they are not able to have a proper ventilation, and these disorders are like COPD, interstitial lung diseases, airway and interstitium. They are chronically damaged, so interfere with the proper ventilatory process, causing type 2 respiratory failure. Obesity, yes, very important. Who has mentioned this? Okay, Mysore people, very nice, very good. Obesity comes in this group. Chest wall disorder. Remember, there is so much of fat over the chest wall that patient is literally struggling for a chest wall expansion. So this severe obesity causes type 2 respiratory failure. Main reason due to chest wall decrease movements, chest wall a sort of stiffness. Patient is not able to expand the chest wall fully. So hypoventilation. So it is a very important cause, usually unrecognized by the patient as well as the physician as well as the doctor, but a very important cause of hypoventilation. Now the Second disorder of respiratory is respiratory alkalosis. So respiratory alkalosis means there is a stimulation, a primary stimulation of respiratory centers. So treatment of respiratory type 2 failure will be the treatment of individual causes, and these individual causes we will read in detail in the respiratory section. So treatment of individual causes. Last okay, so I think let's see whether we can do undo. Okay, so this is the last slide. Chest wall stiffness, ankylosing spondylitis, kyphoscoliosis, obesity, and airway interstitium is COPD and ILD and ILD. Nerve and muscles, it is again like Guillain-Barré syndrome. The mainstay of treatment is either IVIG or plasmapheresis. That will take care of the neuropathy part, and patient might recover. For muscles, unfortunately, these dystrophies, muscle dystrophy, Duchenne muscle dystrophy and Baker's muscle dystrophy, there is nothing that we can do. It is a progressive disease. Steroid were used, plus minus effect. Ventilation was used for these patients, but in the end they usually die of respiratory failure, whatever we do. So there is no definitive treatment for myopathies or dystrophies, but yes, for nerves, Guillain-Barré syndrome, we have plasmapheresis or IVIG. Now coming to the respiratory alkalosis. So respiratory alkalosis is the stimulation of respiratory centers, primarily respiratory centers primarily. It is not due to say metabolic acidosis, which has a compensatory stimulation. This is a primary stimulation. So this respiratory centers can be stimulated from central cause, that is the cause is in the brain, or it could be a peripheral stimulus. So question is the uncal herniation, that means the brain herniation. Yes, if remember, if respiratory centers are compressed and they have a decreased blood supply, then it will lead to hypoventilation. Now central cause which stimulate respiratory centers are first drugs, and two important drugs which are stimulating respiratory centers. First we have done salicylic acid, that was independently stimulating the centers, and second is progesterone, though it is a hormone, but it do stimulate respiratory center. It is increased in pregnancy, so pregnant female will have hyperventilation. Then central cause can be some irritative lesions which can irritate respiratory centers and can cause stimulation. So they are usually infections like meningitis. And of course anxiety, or maybe we can say hysterical disorders. To gain attention, patient hyperventilate, and that is commonly seen in cases of young female who tries to gain attention, seek attention. This you must have seen in your internship during the casualty posting, that a female is coming with hyperventilation with respiratory alkalosis. Then peripheral stimulus, it can originate from yes, of course, lungs. So here make a very important concept, and that concept will be useful to you in understanding respiratory failures in the topic of respiratory system also. So in lungs, if there is alveolar hypoxia, it stimulate respiratory centers. So there will be a stimulus that the depth and the rate of breathing will increase. So when does respiratory hypoxia occur? Etiologies. This is a alveoli, and alveolar hypoxia means decreased oxygen inside the alveoli. So this will occur when there is a alveolar filling. So alveolar hypoxia, that means there is a deficiency of oxygen inside the alveoli because of alveolar filling. So oxygen will not be able to enter inside the alveoli, those which are involved. So this gives a stimulus to the respiratory center to work more, and there will be a hyperventilation. So this alveolar filling can occur in cases of pulmonary edema. Fluid is there in the alveoli, or exudates in the alveoli. And this exudate occur because of ARDS, or can occur because of pneumonia. So remember, pulmonary edema, which is CHF, exudates, ARDS or pneumonia, they typically causes hyperventilation or respiratory alkalosis. Then the second peripheral stimulus is it a type 1 respiratory failure? Yes, you are right. This is one of the cause of type 1 respiratory failure. There are other causes of type 1 respiratory failure. So this is one of the cause. Second is systemic causes. And systemic causes include fever. It include hepatic failure. Reason is not exactly known. How does hepatic failure causes hyperventilation? But it do cause sepsis. Sepsis. So in fever and sepsis, it is the cytokines which are stimulating respiratory centers. Cytokines stimulating the respiratory centers. So this is a list of respiratory alkalosis, that means PaCO2 is low. PaCO2 is low. So we have done the etiologies or causes of different types of acid base disorders. Some we have discussed here and some we have left for the systemic topics like kidneys, where we will do Barter's and Gitelman. Respiratory system, a little bit of that we will do in the respiratory failure also. So this was a brief outline of different disorders. Now coming to the next important disorder, and next important disorder, or we can say the topic, not disorder, topic is very important: analysis. Analysis of acid base imbalance. Acid base imbalance. You have seen many questions which have given, like pH is given, CO2 is given, bicarb is given, and you are asked ki which disorder is it. So we will go step by step. So in the analysis part, number one is always look for the history. And this is a very important point. On the basis of history, we can recognize which disorder is it. Is it a metabolic disorder, or is it a respiratory disorder? Is it an acute disorder or a chronic disorder? So always look for the history. Now second point, look for pH. So if we have taken the pH, normal pH range of 7.34 to 7.44, this was a normal range, but with the normal range we can't calculate anything. So we have to take a single point value, and for pH take 7.40 as a single point value. 7.40 for calculation purpose. For example, if pH is given as 7.36, suppose this is in the normal range, but from 7.40 it is low. So this condition we will take as acidosis, though it is within the range. Similarly, 7.42, it is within the range, but it is more than 7.40. So we will take it as alkalosis. So remember, your value will be 7.40 as a single point value. 7.40. Now, how to say that this value abnormalities are metabolic or respiratory? This is very important, especially if history is not given. So we move to step number 3. So step 3 is to determine respiratory or metabolic cause. Look for PaCO2. Look the value of PaCO2 and pH. So we have to take two values simultaneously. Isolated value, no meaning. So PaCO2 and pH, if they are in same direction, it is a metabolic condition. So normal values if we will take of PaCO2, normal value is 40 and pH normal value was 7.40. So PaCO2 is 40, pH is 7.40, normal values. So if they are in the same direction, let's see what is the meaning of same direction. If PaCO2 is 60, 60 means it is increasing. Normal value was 40, 60 increasing. pH is 7.50, it is also increasing. It is also increasing. So same direction, increase, increase. This will be a case of metabolic alkalosis. Metabolic alkalosis, because they are in same direction. They are in same direction. PaCO2 and pH. Example. PaCO2 is 20, decreasing. pH is 7.20, decreasing. So this is a case of metabolic acidosis. This is decreasing, this is decreasing, same direction, same direction. So metabolic condition. Then if PaCO2 and pH, they are in opposite direction, it is a case of respiratory. It is a case of respiratory. Example. PaCO2 is 20, it is decreasing. pH is 7.50, it is increasing. So opposite direction. PaCO2 20, pH 7.50. This is a case of respiratory alkalosis. Respiratory alkalosis. Second example. PaCO2 is 60, pH is 7.20. So PaCO2 is increasing, pH is decreasing. So this is a case of respiratory acidosis. Respiratory acidosis. Opposite direction. Opposite direction. So step number 3 is a very simple step but a most crucial step, because it is determining your primary disorder. Primary disorder. Then you move further. But if you are not able to diagnose primary disorder, you can't move further. Also, in third point, from that table, if you remember initially, we made two conclusions. First conclusion was the direction of bicarb and CO2 is same. CO2 and bicarb is same. So can we make a conclusion that if bicarb and pH same direction, it will be metabolic? Yes, it is true, because bicarb and CO2, they change in same direction. They change in same direction. So if example is, so how to differentiate between respiratory acidosis alkalosis and compensatory respiratory acidosis alkalosis? We can differentiate from step number 3. If 3 shows the opposite direction, it will be a respiratory condition. It will be a respiratory condition, and if it shows the same direction, it will show that the primary disorder is metabolic. So it is easy. So it is step number 3. Step number 3, that respiratory acidosis alkalosis, the primary disorder. Remember, primary disorder will be either respiratory or a metabolic. If the primary disorder is metabolic, then it will be a compensatory respiratory acidosis alkalosis. Compensatory, not a primary, not a primary. So step number 3 is for primary disorder, is for primary disorder diagnosis. So if bicarb normal values, we have done bicarb, we have seen, we have taken a point value of 24, pH was 7.40. So if bicarb is 30, pH is 7.50. So bicarb is increasing, pH is increasing, same direction. It is a case of metabolic alkalosis. Metabolic alkalosis. Similarly, if bicarb is 20, pH is 7.20, bicarb decrease, pH decrease. It is a case of metabolic acidosis. Metabolic acidosis. So either you take bicarb or you take CO2 and compare it with pH, conclusion will be same. Conclusion will be same. So if step number 3 is clear, then we move to step number 4. Step number 4. So step number 4 is from 3 we have determined what is the primary disorder. Now let's look at the what is the compensatory response. Whenever there is a primary disorder, body will try to compensate it. So in the 4th step, we will try to look for a compensatory response. Compensatory response. So how to calculate compensatory response? So let's see, if we have a primary disorder is metabolic, suppose. So what is the compensatory mechanism? It was respiratory system. So compensatory, what we will calculate? So we will calculate compensatory PaCO2. Remember, whenever there is a primary metabolic disorder, lungs are compensating. That means there is a change in CO2. That there is a change in CO2, and that change in CO2 is a compensatory response. Compensatory response. So from step 3, if the disorder is metabolic, we calculate compensatory PaCO2, or we can say what is the expected PaCO2 due to hyperventilation or hypoventilation. So the simple bedside formula, and this formula you can use in your exams. In exams there is a lack of time, so you should be very fast in calculating the these responses, though there are many other formulas for calculation. So expected PaCO2 is equal to bicarb plus 15. Bicarb plus 15. This is a given bicarb which is given in the question. Given in the question. So It is a very simple formula. Expected PaCO2 is equal to 15 plus bicarb. 15 plus bicarb, which is given in the question. That should be the expected PaCO2. That should be the expected PaCO2. So it is calculated when there is a primary response as a metabolic response. So the questions will be very simple, if pH is 7.28, bicarbonate is given as 15. So anyone can tell me the primary diagnosis and the expected PaCO2? What is first diagnosis and then expected CO2? Yes, it is simple. It is metabolic acidosis because pH is decreasing, bicarb is decreasing. So diagnosis is metabolic acidosis. So let's see what will be the expected. What we have to calculate expected PaCO2. Yes, all of you are right. It is equal to, given bicarb is 15 plus 15 we add, equal to 30. So expected PaCO2 should be 30 here, 30 here. Normal CO2 is 40. So it should be hyperventilation here, which is responsible for a low PaCO2. That will try to compensate. So PaCO2 here is the expected PaCO2. Now this is the very primary simple calculation. Suppose remember, calculate from this equation because of lack of time, but if options are given ki which of the following is correct, equation of compensation for metabolic conditions. So there is one more compensation. In metabolic acidosis, for every what is the primary response? Primary mechanism is the bicarb decrease. For every 1 decrease of bicarb, from which value? From 24. So 24 we have taken as a normal value. So for every 1 decrease of bicarb from 24, PaCO2 decreases by 1.25 from normal value was 40. So this is the relationship. For compensation. This is a second relationship. And in metabolic alkalosis, for every 1 increase, here is an increase of bicarb from 24, PaCO2 increases by 0.75 from 40. PaCO2 increases by 0.75 from 40. So these are the two equations. One is for metabolic acidosis and second is for metabolic alkalosis. So for example, if we calculate from this equation, pH is given as 7.50 and bicarb is given as 30. So this is pH high, bicarb high. This is a case of metabolic alkalosis. So tell me from both the equations, what will be the expected PaCO2 if we will calculate the bedside formula. The bedside formula will be yes, it will be 45. How does 45 come? 30 plus 15. But from this equation of metabolic alkalosis, there is a, for every one increase of bicarb from 24, there is an increase of PCO2 by 0.75 from 40. So in from this it will be, how much it is increasing? It is increasing by 6 units. So it will be 40 plus 6 into 0.75. No, it can't be below 40. It can't be below 40 because PCO2 increases from 40. So it will be 40 plus always. So it will come out to be 44.5, and which is almost equal to the bedside formula or the short formula that we have used. So this will be the difference, 0.5 or maybe 1 difference between these two formula, but easier one will be the first one. So this is for metabolic conditions. Okay, there is a question from Bikaner. Let's see. There is a question from Belgaum also. If PaCO2 and pH is given, is given in question, how to know that it's primary or whether it is primary or a compensatory? Remember step number 3. If PaCO2 and pH same direction, it is a primary metabolic condition. If PaCO2 and pH opposite direction, it will be a primary respiratory condition. So simple that from step 3, PCO2 and pH direction will give you a primary disorder. Metabolic or respiratory. That will be a primary disorder. How does bicarb and pH in opposite direction tell us about respiratory acidosis and alkalosis too? Simple. From the table number 1 we have done in the beginning of the class, there was 2 conclusion. First conclusion was CO2 and bicarb change in same direction. So that means if we are taking CO2 or bicarb and comparing it with pH, conclusion will be the same. All right. So we have lost connection. Repeat from point number 4. So what was the point number 4? That was the compensatory response. So in cut short, point number 4 was calculate compensatory response. So compensatory response. So we are coming to mixed disorder. That will be our point number 5. So first understand this compensatory response. So if it is a metabolic condition, compensation was done by CO2 change from table number 1. So compensation was done by the CO2. So primary disorder we have calculated from step number 3, that whether it is a primary metabolic or primary respiratory. Suppose if it is a primary metabolic condition, we calculate expected PaCO2, and the formula is simple, 15 plus bicarb. which is given in the question, 15 plus bicarb. So it holds true for whether it is a metabolic alkalosis or metabolic acidosis. Now, if it is a respiratory condition, if it is a primary respiratory disorder. How does we say that it is a primary respiratory disorder? From step number 3. If CO2 and pH were in opposite direction, it was a primary respiratory condition. So for that, what we have to calculate? We have to calculate expected bicarb. We have to calculate expected bicarb because that is compensating for the respiratory disorder. So it depends on whether the respiratory condition is acidosis or alkalosis. Also, whether it is an acute condition or a chronic condition. Why this is important? Because in respiratory condition, the main compensation was done by kidneys. Kidneys are slow acting. If it is an acute disorder, kidney might not be able to compensate to their best. That compensation comes after 48 hours. So if it is an acute condition, compensation will be less. If it is a chronic condition, compensation will be more. So there is a difference. There is a difference in respiratory thing. If it is acute, compensation less. If it is chronic, compensation will be more by the kidneys in terms of bicarb change. So if it is a respiratory acidosis, there are two possibilities. First is acute. So let's see in acute what is the compensation. So in acute, for every 1 increase of PaCO2, we have seen from the table that the primary condition or main mechanism of respiratory acidosis is an increase of CO2 from 40. The change will be on the bicarbonate. So what change? Same. Bicarb will also increase. So bicarb increases by 0.1 from 24. From 24. For chronic condition, for every 1 increase of PaCO2 from 40, bicarb will increase by more value because the compensation is more. It will be 0.4 from 24. So for a similar increase, compensation is different. So here for everyone it is 0.1, here for everyone it is 0.4. And remember the basic concept that in respiratory acidosis, compensatory bicarb will be 24 plus. It will be more than 24. So let's do one example before going to respiratory alkalosis. So pH is 7.28. PaCO2 is given as 70. So we all know the pH is decreasing, CO2 is increasing. It is a case of respiratory. Which respiratory according to pH? Respiratory acidosis. Now tell me, what will be the expected bicarb if it is an acute disorder, and what will be expected bicarb if it is a chronic disorder? Yes, very good. So it will be, if it is an acute disorder, 24 plus 0.1 into 30, because CO2 is increasing by 30 units from the normal value. So it comes out to be 27. And yes, very good. For chronic disorder, it will be 24 plus 0.4 into 30. So it will be 36. It will be 36. So you can see the expected value changes so widely depending on whether it is an acute disorder or a chronic disorder Now, respiratory alkalosis. In respiratory alkalosis, it is also acute and chronic. So in acute, in respiratory alkalosis, there is a decrease in CO2. So for every 1 decrease of PaCO2 from 40, for every 1 decrease of PaCO2 from 40, bicarb will decrease. So as a basic concept, in metabolic alkalosis, bicarb will be 24 minus. Bicarb decreases by 0.2 from 24, while in chronic, for every 1 decrease of PaCO2 from 40, bicarb will decrease by more than 0.2, because compensation is more, 0.4 from 24. So here the ratio is, for every 1 decrease, 0.2 decrease, for every 1 decrease, 0.4 decrease. So let's do one example. pH is 7.51, PaCO2 is 20. So we all know it is a high pH, low CO2, it is a respiratory alkalosis. So what will be expected bicarb in acute case and expected bicarb in chronic case? So let's see who will make it fast. Yes, Hubli people have done it. It is 20. How 20? 24 minus 0.2 into, how much was the decrease? 20. It comes out to be 20. No, it is not never more than 24. Remember, it will be 24 minus. And for chronic, 24 minus 0.4 into 20. this comes out to be 16. This comes out to be 16. So it is a mathematical calculation with the concept that in respiratory acidosis bicarb will increase 24 plus, while in respiratory alkalosis expected bicarb will be 24 minus. So this plus minus is very important. In alkalosis, respiratory alkalosis, bicarb decrease. In respiratory acidosis, bicarb increases. So these are the four primary step of calculation of acid base disorder, and these are, we'll say, is a very simple process to follow. Now before going to the complex procedure, should we take a break or will continue, because that will be our step number 5. Okay, so we'll take a break because their votes are going more in favor of break than continue. So during this break, just revise table number 1 and just revise the analysis part, and we will do examples after doing these steps. So class is till 9 o'clock today. Break is for moving on to step number 5. From now onwards the step will be slightly more complex. Till step number 4 things are very easy. All right. So we'll start because break was of 5 to 10 minutes. So moving on to step number 5. So why there is a wait, because today we have to start with the GIT also, finishing this acid base balance. We have aims but classes are scheduled. Remember, there is no class on your exam, no class on aims exam, that is on 11th the class is not there, and I think on Saturday there will also not be a class. So 10th and 11th for regular batch there are no classes. It will be foundation batch which will be having classes. So because of aims, classes we have postponed. So you can give your exam, and so moving on to Step number 5. So hang volume. So is volume clear? All right, so we will start. Why we don't regular batch do not have class on 10th and 11th of May because of AIMS exam. So regular batch no class, but foundation batch there will be a class. So moving to fifth step. So fifth step is to be done when there is discrepancy between the given value and your calculated value so it is done when calculated. What will be the next schedule for regular? I think this is on next Saturday, Sunday. Class will be there, and it will be continuation of medicine class. So voice is hanging. There is a audio problem. From 3 centers. There is a voice problem. Audio. Voice. Is it clear? सभी जगह से आ रही है प्रॉब्लम. सभी जगह से